Oksana has a problem with her internet. It may happen any moment, so I can say that today we have the 4th International Medical Conference, which is dedicated to treatment of patients with Duchenne. And today we have Professor Marcello Villanova, who agreed today to tell us, to share his experience, practical experience. This is the professor working in neuromuscular unit, and he is a specialist on neuromuscular points. Oksana? Unfortunately, I have bad connection. Does professor know about interpretation? Yes, yes. So, dear professor, the floor is yours.
Будь ласка, звук. Не чути. Звук. Так.
Do you hear me? Okay.
Ні, так.
Okay. So let's, first of all, I thank you for the invitation. And I'm really very pleased to meet here. My English is not so perfect, but I will try to do my best. And what I'm going to do today, I'm a neurologist. Since 1991, I follow patients with the neuromuscular disorders. I did long trips during my life. I worked with the people such Michel Fardot in Paris or John Bach in the United States, and abroad in Italy, all the experience that they had following the patients. In the last 30 years, I've been following hundreds of Duchenne patients. And actually, I'm the head of neuromuscular unit. And I didn't make a right count, but probably I'm following more than 100 Duchenne at the moment. What I'm going to do is just today to show how to follow Duchenne, or at least how I follow a Duchenne. Because many times, you know, also amongst us, amongst the specialists, the way to follow Duchenne may be a little bit different. Someone may have different ideas. But what I always say that is the oldest Duchenne teach us the mistakes and teach us what we should not do when we see, for example, patients that actually have 30 years old or 40 years old. And this, from them, we start to make a better life for them. Now, first of all, I would like to say that a Duchenne patient doesn't need a quantity of life. We should work a lot of quality of life. Because many times, you know, we think that to let the Duchenne patient live 30 years, 40 years is the only target. But I think, and these, I can tell these things because, you know, I speak with Duchenne patients every day. They really want to have also a good quality of life. And we have to work a lot on this topic, and not only on the quantity. Now, we know very well that if you have to follow a patient with Duchenne, you need a lot of specialties. And you should do an approach that is a team approach. But unfortunately, at least this is my experience, it's not easy to put together all these doctors, all these specialists. And a neurologist, or at least someone that want to follow patients with neuromuscular disease, should have a multidisciplinary knowledge. So for this reason, I have been studying pulmonology, cardiology, neurology, physiatry. So I put in my head a lot of specialties. And then I ask to my colleagues many times some opinion, but it's very important that the supervision who follow Duchenne patients as himself, as a neurologist, the knowledge of many branches of the medicine. I will show now 1, 2, 3 books. These have made the story of Duchenne. We see this book are books that, you know, we read 20 years ago. This is from Frank Mastaglia, but then we have one from Alan Emery. Then we have also from Victor Dubowitz. They made the history of neuromuscular disease. But when you read these books, then you see always that Duchenne was dying when he was 20, probably a little bit more than 20. So they were very depressive books because actually this never happened anymore. It's practically impossible that Duchenne patients can live less than 20 years. I don't remember a case in my life in the last 20 years. In effect, this is Paulo. Pauli he is 53 years old, and he has Duchenne. I publish this case because he's the oldest Duchenne in the world. But just to let you to show that there are Duchenne that can live also very, very long life. Unfortunately, Paolo died 2 years ago. Probably he was one of the first COVID patients, and he was not in Bologna, he was in his house, but unfortunately I lost Paolo 2 years ago, but he lived until 54 years old. So this means that Duchenne patients can live very long. It depends always by the treatment, and many times also by the heart, because the lucky of Paolo was to have, he had a very good heart, and the dystrophy probably was in his heart. For the rest, he had a very, very severe disease. Now, we know very well the 3 phases of Duchenne. I think I'm not teaching my colleagues that generally, when we speak about the natural history of Duchenne, we have to divide their life in 3 phases. The initial phases, generally between 0 and 6, and I call the diagnosis phases, in which generally we make a diagnosis. You see sign very typical, the calf hypertrophy, but many times, you know, the pediatrician doesn't make any diagnosis because, you know, the boy looks normal. And many times the boy looks also with very good muscles. And most of the time, the diagnosis is made by the mother. And the mother, because I see the difference between, for example, is a child from other children that they have, and they say to the doctor, you see, for me, my son has some problems. Many times, also the pediatrician can make a diagnosis. They say, okay, it's okay, don't worry. You will see that he will improve, it's just a period. Then they make a blood examination and they discover to have the Duchenne. Most of the time, the diagnosis between 0 and 3 and 0 4 years old happen with casualties because, you know, you make an examination for other things, you find a very high CK. Then we have the transition phase in which Duchenne patients, these are old pictures, you know, but just to say the phenotype, you see the hyperlordosis, you see the retraction, you see the Achilles tendons that start to retract. So there is a phase in which our target, I will show you, will be to prolong as maximum as we can their deambulation, because it's very important that Duchenne patients walk as much as possible. And then we have the 3rd phase that is not ambulatory phase, in which we have to think about other things, for example, scoliosis, the heart, and the ventilation, and the autonomy thanks to medical device and other things. So generally it starts when they are 12, but sometimes can be 13, sometimes can be 11. It depends by boy to boy. And it depends also by the history of the boy until that age. So what should we do? And this generally in these phases, generally in the initial phase, we have to work with physiotherapy. First of all, you have always to think that these are kids, and the kids, they have to live as kids. So otherwise they will become more sick than they are. Generally, I let them to live as normal as they can, but what I suggest to families just to start a bit of physiotherapy, just to let the child know what is physiotherapy. And then we start to use orthosis, but then I will come back later on this topic. Then in the intermediate phase, our principal target is to prolong walking. So we have to work to prolong walking, and I will show what we do to prolong walking. But we will speak about drug treatment principally, and we will speak about steroids. Then we have a non-ambulatory phase in which the boy unfortunately lost his walk, his autonomous walking. And we have to think about then other very important things. It starts the most difficult part of their life, in which you have to look very careful to the scoliosis, to the heart, to the respiratory treatment. So we have to put our attention on other things. Unfortunately, today I have not time to speak about everything, but I thought to speak you about ventilatory problems and also scoliosis. Then, if someone wants to make questions about heart disease or other things, is completely free to do it at the end of the communication. So the objective that we have to follow, of course, it depends by the natural history. Now we know very well the natural history of Duchenne. Probably is the only disease, neuromuscular disease, in which we know very well the natural history. So we cannot make mistake, because when you know very well the natural history, you know what will going to happen. And in that case, you have to prevent and not to arrive late when already the problem is there and you cannot do anything. For example, these are very terrible things. These are, I call unnecessary complication. I cannot see anymore people arriving in Bologna with such scoliosis and such position of a boy that arrived in Bologna with such wheelchair, sitting in that position. Then we tried to work on him, and this was his wheelchair. Later on, we did our job. Of boys that when they are already 6 or 7, they arrive with very bad retraction of the Achilles tendon, and they walk just because there is the hand of their mother. But it's not possible in 2023 to see kids like this arriving when they are 6, 7 with such feet. These are also very bad feet. Feet of boy that has 9 years old. You see the feet are completely, the retraction is completely of the Achilles tendon. You have a complete equinus of the feet. So which are the targets that we have to take in consideration when we follow Duchenne patients? First of all, we have to preserve maximum autonomy for as long as possible. Then we have to try to counteract the aggravation of clinical sign. So we know which are the clinical signs. We know what will happen a boy that in front of me as a 3 years old, but when I see a patient with a 3 years old, I already imagine him when he will be 20. So for this reason, I have to try to avoid everything that is possible to avoid. We don't need, these boys, they don't need unnecessary complications. And if we follow them very well, they will not have unnecessary complications, because at the end, their life can be much worse if we make mistake. Then we have to try to work on the compensation, and we have to try to delay as possible as we can the worsening evolution of the disease. So for this reason, you need a deep knowledge. You cannot invent a specialist in Duchenne. So if you have an experience in Duchenne, just be humble and say, you know, I never seen Duchenne, or probably I have seen only 2 Duchenne, and go someone else. So you cannot follow Duchenne patients if you have not a deep knowledge. And you can try to work on it. So you can study, you can enter in contact with other colleagues that have experience with Duchenne. But you cannot think also as a neurologist to follow Duchenne patients if you never know or you have never seen a Duchenne patient. And sometimes today happen that someone become expert in Duchenne also if has never seen one of those, or probably has seen one or two of those. My experience taught me that you need a lot of years to become a specialist in such kind of complex diseases. So let's speak now about what we do to prolong independent walking. And we have to start by the physiology, because if we know the physiology of the walking, then we can understand how to help a boy with Duchenne to try to walk independently long time. Which are the factors that probably, but this is happen also for us, that let us to have problems to walk: pain, strength, contractures, equilibrium, spinal deformity, muscle fatigue. So all these things can make the walking of boy of Duchenne, but I would like to say also in a normal boy without any disease, problematic. So when you walk, you want to walk in a good way, you need a good stability. The feet are very important. If you don't work on the feet of Duchenne, then you will have problems to walk. And many times Duchenne stop walking not because they are weak, but because the feet are so terrible that they cannot more walk anymore. They have bad problems with the equilibrium. And many times they can stop walking when they are 7, just because, you know, no one thought about their feet. And of course, you need a good muscular strength to have a normal gait. In Duchenne, what happens? So we know very well that there are muscles in Duchenne that are weaker and muscles in Duchenne that are stronger. And for this reason, you have you can have contractures, and in Duchenne you have those because, you know, all the flexors are stronger than the extensors. For example, the weakness of the hip extensors, then you will try to develop hip flexors retractions. The knee extensors are weak, and for this reason, the knee flexors are stronger, and this will generally produce muscle retraction to the knee flexors. And so also on the foot, the dorsiflexors of the foot are very weak, or at least are weaker than the plantar flexors. So we know very well which are the muscles are weaker, and for this reason, we have to be very careful. We have to try to limit the muscle retraction working on this physiological data that we have when we see a patient with Duchenne. So, and for this reason, for example, the weakness of the hip extensor, what does? Practically forward the center of the body. And for this reason, they develop hyperlordosis. And also, when you have a very weak quadriceps, then you will walk on the tools. But, you know, this makes the walking very unbalanced. And sometimes, you know, a Duchenne boy is normal that he walks on the tools, but it's very important that the ankle does not retract, the Achilles tendon does not retract. So we have to be really very careful to try to avoid retraction that then will make very important problems for these boys to walk, or anyway to have a good normal gait with good equilibrium. And so for example, weakness in dorsiflexion of the foot will facilitate retraction of the Achilles tendon. So, and the role of the physiotherapy, the targets is just to try to prevent damage and to try to slow down the decline of muscle strength and maintain autonomy. So the physiotherapy play this role. We have to try with the physiotherapy and also using orthosis, you will see, to try to prevent, or at least to let the damage much less worse than could be if you didn't do anything. At the end, when the boy is a little bit older, then you have to work also on the respiratory treatment. So you have to choose very carefully orthosis, and you have also to choose very carefully wheelchair, and because these will play a very important role in the life of these boys. Very important at the end is also the family training. The family, I think, is the best nurse for these boys. And for example, especially when they get older, I see mothers that know more than intensivist or more than pulmonologists, because, you know, we teach family to use ventilators, cough assist, aspirators. So sometimes mothers with only very low school diploma, they are really incredibly clever nurses, but they work on their child better than they could do in intensive care unit. So we train a lot of family. We try to explain the family what they have to do to try to avoid as much as they can damage to their children. Because, you know, in Duchenne, you have this very bad vicious circle, and you have to work on one of these. You see, muscle weakness can make imbalance, and then the imbalance can create deformity, and then you can have rigid contractures and compensation. So, you know, we have to try to just avoid this vicious circle. And today we can, because when you know the natural history and you know what to do, then generally you can avoid this, you can break this circle. You see, for example, in the transitional phases, said before, the hip flexors are stronger than the hip extensor. So then you can develop contractures on the hip flexors. And the same on the dorsiflexor, the foot, because, you know, the ankle dorsiflexor is weaker than the plantar. And then you can have, for example, contractures of the Achilles tendon. And if you are not very careful to this clinical important sign, then you will have a bad feet, because, you know, if you don't take care about the foot of your Duchenne patients, then you will develop very bad contractures, and as I said before, he can stop much earlier to walk than he could do. For this reason, you know, these are examples, but for example, is a boy arrived at 6 years old with already 35 degrees of retraction of the Achilles tendon. Generally, you have to do the sum between 90 and 33. So in this case, is 125. This ankle. But when a boy is 6 years old, the foot should be like this, you need 90 degrees. This is good foot. So you have to try as much as you can to try to keep the foot of the Duchenne boy at 90 degrees. In that case, he will not have much problems to walk. What we do, of course, we use orthosis. Now, you know, when you listen other scientists in the world, many times they say, you know, the Duchenne patient doesn't need of orthosis. But my experience, that is almost 30 years of experience, tell me that these orthoses are very important. I've seen, if you put these orthoses, we generally start when the boy is 3 years of age. It's very important because, you know, if you think that with only the physiotherapy you could delay the retraction of the Achilles tendon, I think is not possible, because you should need 6 hours a day of physiotherapy to do the work that does an orthosis. Of course, what is very important is that the child should not be obliged to put orthosis, and you have to be very careful. You have to have a lot of patience, and what I do is just make them colored or say to the parents, when you know, tell your child to put only one in one night, the other one the other night. So the child has to be to go near this orthosis slowly. Never be obliged to be aggressive with children, because this is not good. So we put orthosis, and I think this is a very good help. And orthosis, they are very light. Sometimes use polyethylene, but 2 millimeters of size, and they are really very, very light. Because our goal is to arrive at 10 years of age with such feet, and not with feet like this. This is our goal, because, you know, also if a Duchenne patient stop walking, if he has good feet, then he can also stand, also with standing, you will see later. But if he has feet like this, he will not stand, because it's impossible. It's impossible. He will sit. But if he sits in a wheelchair when he is 10 or probably 9, then he will develop very bad scoliosis, as many times happen. So more these kids are in upright position, then less scoliosis they will have. So it's okay. This is okay. As I said before, it's very important to act on the progression of the detection, but I already explained this point. Now we have also surgery. So in some cases, when probably you cannot do anything, or probably the boy arrived too late, in those cases we use surgery. And you see, with mean invasive surgery is a subepidermal tenotomy. So there are orthopedics colleagues that are very clever. They don't do open surgery, they do just really mean invasive surgery. One foot like this can become again like what we want, so 90 degrees. You see it before and after. See this and this. So we use also, as we see, a medical device just to prolong the upright position. In the past, we use these orthoses, but we don't use anymore since I'm at least in my unit 15 years, because these orthoses generally, first of all, they are very dangerous, because if the boy fall, it's terrible, because, you know, they are blocked, and when they fall with such orthosis, they can have a very bad trauma. And also because with this orthosis, they try also to walk, but when they walk, they stress a lot of the heart, because, you know, it's not easy to walk with this such orthosis. Then these orthoses are the history. Now we don't use anymore such thing. We use this standing. They can stand upright very, very well. And we also have a wheelchair with that can put the boys in an upright position. But for example, many times they use such kind of this is an easy stand. We use the easy stand. We can change the positions. So they are very, very good to let them to stay also an hour, 2 hours a day in upright position. Now, another thing that we use to try to prolong the walking, but anyway, to delay the disease, is the steroids. Today, we have also other therapy that we call innovative therapy. But unfortunately, actually, until now, no one in the world has left steroids. So if you see all the trials, they use innovative drugs, but the boys never stop steroids. So it means that the steroids that are very, very old drugs, we know very well how they work. We know very well the side effects, are actually the only drugs that improve with certainly the clinical findings of these boys. And the steroids, what does it do? Generally, you know, increase muscle endurance, slow down the progression of the Duchenne, and also increase muscle strength. And when we visit the patients, we do all these tests. We do functional tests, we do myometry, we do manual muscle testing. So we know very well, and we are sure that the steroids do such a job. Generally, we start at when the boy is 3-4 years. It depends. Sometimes we start at 4 years when there is a delay of the mental situation. If there is a cognitive impairment, we try to start a little bit later because, you know, sometimes you know, the boy doesn't tell you if he has some side effects or anyway. You cannot try to, or it becomes very difficult to try to understand if the steroids are working or not, because you cannot test very well Duchenne boy with important cognitive impairment. And we have a different administration scheme. For example, you can give steroids every day, every other day, 10 days yes, 10 days no, high dosage. So we have a different scheme. Generally, I start always with the schema that gives very few side effects. For example, 10 days yes, 10 days no. Then I see how it's following. For example, I have a Duchenne that actually are 12 years old that are taking steroids 10 days yes, 10 days no since 9 years. And they go very well. So it's not always, we are not always obliged to give steroids every day. We have to follow, see the results, and if the results does not convince us, then in that case, we can change the schema. At least this is what I do in Bologna. And what are the side effects of the steroids? We know also this very well. You can have hypertension, so you need to ask the pediatrician to check the blood pressure at least one times every month. Then there is a problem of the osteoporosis, but actually, if you give vitamin D and calcium, generally they have never bad osteoporosis, at least when they get older. But you know, osteoporosis is always present in Duchenne patients because it depends by the fact that they move less than a normal boy, and this clearly is a point that may favorite osteoporosis. Then, you know, steroids can give growth delay and low stature, especially when you give a lot of steroids. I've seen boys arrived with a very bad low stature, but fat, because they were taking steroids every day, but without checking or anyway without thinking about also these things, because you know, we think always to try to let them to walk, but of course other factors are very important. Also the phenotype is very important, because these boys, when they see themselves on the mirror, they like they want to see in front of them a normal child, or at least as normal as possible. And sometimes you have, you know, boys 12 years old that are very with a very low stature. Then obesity, you have to be very careful to the diet, to the nutrition, and irritability. So for this reason, we always say the parents, you know, if you see your child getting very angry many times, then can be steroids. And also, not all children respond to therapy. Very few children with Duchenne, they did not respond to steroids. So generally they respond, but I have really very rare Duchenne patients that did not respond to steroids therapy. So what we do, generally, these are the examination. You should make densitometry, vitamin D, calcium, Then we use also biphosphonate when, for example, I start when they are already 10. And then you should just check the weight very carefully. You have to speak with the parental. So the who follow Duchenne should be sure that the therapy doesn't give a lot of side effects and probably less good effects. Now we stop about, we have seen what we do generally in the initial phase, what we do to prolong their walking. Of course, we have not much time to speak about everything, but today I also I thought to speak about ventilation because I think it's very important. And also in this case, you should need 2 hours, 3 hours at least to speak all the things about ventilation. But I will try to speak about few points, very important points. First of all, this is Italian, but anyway, we breathe with the muscles. So it's very important to understand that we have inspiratory muscles and expiratory muscles. And generally, in Duchenne patients, the expiratory muscles are the muscles that get weaker earlier. And for this reason, sometimes you can have problems with cough and you can have a bronchopneumonia before someone understands that there are respiratory problems. This is generally, well, I would like to say in all neuromuscular disorders. So you can have a hypoventilation because the muscles become weaker. You can have inability to cough because when you have respiratory muscles weak, you are no more much strength to cough, and also the scoliosis can worsen the situation. For example, so when we see a patient with Duchenne, but we can speak about neuromuscular disorders because when we speak about ventilation, all neuromuscular disorders probably are the same. You have an initial phase in which you have normal functions. Then you have a second phase in which the boys, they breathe normally, but they have an effective cough, and we have to be very careful for that. Then we have a third phase in which during the day they breathe very well, but during the night the problems become there because the ventilation is inadequate. And then we start nasal ventilation, for example. And then when the Duchenne patients can breathe in an adequately way during the night and during the day. To monitor the respiratory function, you should do, and I'm just telling this to the colleagues, but the spirometry is very important. It's very important to do spirometry in a sitting position and supine. Then you have to check the peak of flow. That is another test that is very important because we can understand whether a boy with Duchenne can have problems if he gets some cold or worse pneumonia. Then you have to do generally enough nocturnal oximetry to check whether during the night they have a desaturation. And we use also capnography. Generally, we don't, well, I use also Immorgas Analysis, but it's more invasive. Generally, also the capnography is very good, at least when they don't do 24 hours ventilation. So you can check the CO2 with a non-invasive way. When it's necessary, we do Immorgas Analysis. And this is for families. What should you do to avoid risk? First of all, you don't wait that the respiratory failure is too bad. So if you have to go to the hospital with a ventilatory problem, you have to go immediately. So don't wait. And today we give to the family saturimeter, and the families can understand if eventually the desaturation is very bad or is not so bad. And in that case, you can wait. If you are not able at home to treat your child, or anyway, you see that things start to become dangerous, then go to the hospital. Don't arrive too late, because if that hospital has no experience, If your child arrives at hospital in a good way, then we'll try to treat him. But if the child is in a bad situation, and you go in a hospital and they don't know anything about how to treat a Duchenne patient, then the child will get the worst things in the hospital. So, of course, you have to try to avoid as much as you can intensive care unit, because when you arrive there, then everything becomes difficult. You need really a lot of experience to extubate a patient with Duchenne. Another thing very important is to have a specialist near your house. This is a dream of all families, to have a specialist near their house that understand very well. And it's very good that in Ukraine also there are colleagues actually that are specialists in neuromuscular disorders. They can also treat ventilatory problems. So this is what John Bach has taught me in the United States, but this is very important, and I tell this, this is for colleagues. So you see, when you have a respiratory problem, you have a desaturation, so the PO2, the oxygen goes down. But when you have a ventilatory problems, in that case, you have to be very careful to the CO2. So because your problem will be that the carbon dioxide will go up. And the mistake that many times is made is that when you arrive with a boy with Duchenne to the emergency room, and he is desaturating, so for example, he has 80 of oxygen, the first thing that they do many times is just give oxygen, but they don't treat the cough inability. They don't treat the mucus. So in that case, the oxygen improve the saturation, but unfortunately it doesn't improve the mucus that grows. So the CO2 will grow, and these boys, they will need of 1 liter, and then 2 liters, 3 liters, 4 liters of oxygen, and then they go in coma, hypercapnic coma. And in those cases, the best thing that they do is just to intubate these patients. But this is really a mistake, because if you know Duchenne, or anyway, if you have experience in neuromuscular disorders, you give oxygen, but you treat also the cough inability. You use the cough assist machine also in emergency room. And this is explained why the oxygen many times is poisoning the Duchenne patients, is not helping. So it's not bad to give oxygen, but don't forget never that Duchenne has difficulty in coughing. So you have to know how to clear the airway. This is the peak outflow. It's very important, the test. So if you have a peak outflow less than 270 liters a minute, then you need to teach the families the cough assist. And when you do the follow-up of Duchenne every 6 months or every year, it depends by the age, this test should be always done. And when it's less than 270, you need to teach how to use a cough assist. You cannot wait, because in that case, you know, the boy is well, he can cough. And many times the families say, you know, my boy has never problems, he never take influenza. Don't care about it. If he has a peak outflow less than 270, teach the family to use a cough assist, teach the boy to use cough assist machine. What we do training. You see, these are mothers and that teach to use ambu bags, cough assist. So, and the best thing to do is just to educate the families to treat these things, because, you know, the families is the first emergency room that a boy has. And if they know how to do it, I can tell you, and for sure, that you don't need most of the time to go to the hospital. You treat your boy at home. So this is a slide just to say when we start nasal ventilation, and generally we start nasal ventilation when the the PaCO2 is more than 45 during the day, or you have symptoms of hypoventilation during the night when you do nocturnal oximetry. For example, you have to be very careful because sometimes they need the ventilation when the spirometry showed forced vital capacity less than 50%, or they have less than 15 milliliters kilograms of air in their lungs. Or if they do many times, for example, they have problems with the bronchopneumonia. So you have to think also about to start nasal ventilation. And if you use those in a good way, you will see that you will have in your country, but everywhere, less morbidity and mortality. You will have less days of hospitalization of these boys, because if a hospital knows very well how to treat them, you don't need to stay 1 month in an intensive care unit. You can stay just a few days in normal medicine department and treat the problems. You improve the quality of life. You don't need trachea. The trachea, unfortunately, the tracheotomy is always a mistake because, you know, generally many of these boys get tracheostomy because they didn't find people expert in treating their inability to cough. I have, well, I would, all my patients, they have nasal ventilations. I have only 2 patients with the tracheostomy, but the tracheostomy was made, one because he had a surgery when he was adult, and unfortunately the surgeon said that we have to make a tracheostomy because we are more sure about the anesthesiology problem. So he got a tracheostomy for that. Another one because he had so bad also bulbar involvement, also if it was Duchenne, and nasal ventilation, he's older to be Duchenne. Nasal ventilation was not more enough to ventilate him. So, but practically all of my patients, they have no tracheotomy. Also because you think about also expensive. If you make a trach tube, then you will need, as I said before here, 12 tracheostomy tubes, 300 probes of aspirations, liters of injector solution. You need a lot of money every year. While if you have a patient with non-invasive ventilation, you will spend much less money also for the health system. So at the end, what I can tell you about this is that if you have an untrained patient, an untrained family, then when you get problems with lungs, you go to the emergency room. In this case, what we do generally is they intubate him. And at the end, it's very easy to make tracheostomy. But if you have a trained patient, if you have a trained family, then they start to do physiotherapy. They use a cuff assist machine and at home. And really, this is true. It's very unusual that they go to the hospital. So it's very important to teach the family all these steps, because if they know very well to use a saturimeter and the cuff assist machine and respiratory physiotherapy, they don't need to go to the hospital. At the end, I take just 5 minutes to speak about scoliosis. This is very important because, you know, we don't do any more surgery for scoliosis since many years, and because you know, surgery is very bad. You need 5 hours of surgery. You need transfusions, and can become very dangerous for a boy with Duchenne to have surgery. So. I have to say the truth that we don't do any more scoliosis. So this is not a child with Duchenne. This is a spinal musculartrophy, but we don't want to see any more people with such severe scoliosis. This is an Italian, but it's very important because in these slides, what you can see, this is musky means man. when you are 10 years of age, practically 80% of the length of the trunk is formed. So what does it mean? It means that if a boy walks until 10 years of age, 80% of his back will be done. So it means that the problem, the fact that he will develop a very bad scoliosis will be much less probable. If you let Duchenne walk until 12, then you will have 84% of the length of the trunk that is already made. So older they stop walking, less they will have problems with scoliosis. And in Duchenne, you can have a different kind of scoliosis, and sometimes this is all the picture. You have also hyperciphosis, that is also some Duchenne, but this is really historical because the last 10 years we didn't get any more such kind of problems. Or you can have also hyperlordosis in Duchenne. And hyperlordosis in Duchenne comes because they sit in a bad position. Actually, today with a new wheelchair that have the possibility to have the basculation of the trunk, this problem is not more present. And when you have such very bad hyperlordosis, also the lungs doesn't ventilate very well, especially the lowest part. The scoliosis, if you don't act, can be, so the progression can be also sometimes very, very fast. What we do for the scoliosis? We use orthotic treatment. We use standing, as we said before, the surgery. We say that generally the surgery we don't do anymore. The orthotic treatment, it's very important because you can slow the progression, and you can also help the sitting position. Sometimes I'm sure that other colleagues will not be, they will not agree, and they will say, the corset doesn't help to slow down the scoliosis. This is correct in a certain way, but if you put a corset when they stop walking and when they have no scoliosis, when the curve is very, very light, then you will have a very good results. If you put the corset, orthopedic corset, when already the scoliosis is there, when probably he has 70 degrees of scoliosis, then in that case, you will not have success. But if you put a corset immediately when they stop walking, and let them to have it 1 hour, 2 hours a day when they sit, in that case, the results will be very good. And not only using the corset when they sit, you cannot put corset when the Duchenne walk, but you can put it when they stop walking. As I said before, it is very important to keep that standing, because we know very well from the natural history that the scoliosis will develop immediately when they will sit. When they start sitting, when they stop walking, then the scoliosis will grow very quickly, because they will have bad positions, prolonged bad position during the day, and this will favorite the scoliosis. Of course, if you let sitting a child with Duchenne at 7 years old, and the risk to get very bad scoliosis will be much, much bigger. At the end, just 2 slides. I took these slides from a recent paper, but just to show you that there is hope, and we have several kind of targets to work with therapy, and some of these drugs are on phase 3, so are already in trials on human. You see, there are a lot of molecules, and you have a lot of the targets, because when you think of Duchenne patients, you see you have a lot of targets. You can work on fibrosis, you work on regenerations, you can work on ischemia, so you can work on necrosis. We have different targets. What I can say, this is my experience, unfortunately, until today, all the innovative drugs didn't give good results, or at least didn't give what we were expecting from innovative drugs. I feel that very important in the future will be the cellular therapy, because when you lose a tissue, a drug never make regeneration. The drug can work on the gene, probably can make this the muscle make again dystrophin. But if you have a drug, you should start when the boy is 2 or 3 years old. But when the boy stop walking, or when the boy sit when they are 12, 13, they already lose a lot of muscles, and the drug doesn't make any regeneration. So I think the future will be cellular therapy plus drugs. They should work together, and I'm sure we will have good results. But until now, the cellular therapy had a very bad working, because, you know, there is not much interest in it. Everyone is working on drugs. But for these boys, for these kids, I hope that this mentality will change, and that all the possible way that should be taken to improve their life. And I finished an hour, and I thank you. Grazie.
Дякую, шановний пане професоре.
Thank you so much, dear professor, for this great practical lecture. Really, we heard a lot of information, and it means that you have extensive experience, and it helps to manage the patients the right way. Because in my opinion, the huge achievement is the fact that your patients right now avoid surgeries. Because actually, orthopedic complications very often occur among Ukrainian patients, and I think that it's the same about European patients, and these are great results of your team's work. So now I'd like to invite colleagues, Mr. Volodymyr, to ask questions if we have them. Thank you so much. I'd like to join this conversation, and I want to thank Mr. Professor Marcello Villanova for his honesty and practical experience in management of these patients. So that's the most important thing. We heard in this speech not what is done in the world of science, but we felt how important it is to have your 20-year experience, which you've shared generously with Ukrainian specialists. We really appreciate it. Thank you. Also, I want to say that I also have quite big experience, more than 40 years of practice of work with all populations, not only with 7 patients. I remember the first publications of the book about Duchenne disease, Polish publications from Professor Gusmanova. It was in 1970s. And I remember the practical experience which Ukrainian doctors took when the parents came and couldn't believe that the patients with this disease cannot be helped. And I remember these stages of our Ukrainian search. But first of all, for some reason, we had the period of time when we referred these patients to the USA, and they tried to find biological biocomponents there, like in the previous century. And we thought that maybe it can somehow improve their condition. And also, after that stage of biological supplements, we used neuroprotectors, vitamins, groups, and it was really the whole era of all of these medications. And then again, we understood that it gives no effect. And to date, especially parent society is waiting for the miracle from target therapy, the therapy where the medications are used, the medications which can influence gene therapy, so-called. And I want to thank you very much for grounding this huge miraculous desires of parents to receive some significant changes that would significantly improve the condition of these patients. In your speech, I really liked absolutely everything that is about walking. Walking is highly important, and something that's related to the food. I have already taken this experience and I understand how foot position is important. And really, I liked your approaches from the point of view of surgery treatment that Oksana has mentioned, and your approach to steroids. I will not stop for a long time on that. The only thing I'd like to highlight, which is important for me, and it relates to the fact that we cannot repeat and create the second Marcello Villanova in Ukraine. I don't think someone in Ukraine can deeply understand how to provide the ventilation and how we can learn, how neurologists can learn absolutely different specialty for us. So I'm on the stage of multidisciplinary approach. I'm on the stage that we have to cooperate with anesthesiologists and other specialists here and now. And I'm already thinking, and I will also ask you about that later, that it's really important to have the cooperation with the specialists who understand palliative aid, because all the points you've mentioned, especially ventilation, cannot be done without deeper knowledge about these patients among other specialists. And I will not continue saying more compliments to you. You deserve all the compliments. You are really the specialist of the highest level. So I want to invite you to further cooperation with Ukrainian doctors. And I hope that you will not say no to us, and we will try to agree this process with Margarita Yashchenko or Oksana Nazar about how you can do the workshop with us, not to have the lecture for 1 hour, but so that we would be able to work with you at least a few days. And that would be really the most valuable service from you to Ukraine, which really requires it. And during the war with Russian aggression, I kindly ask you not to deny and refuse. And in 2023, we kindly ask you to work in this direction with us. Now, may I ask you a few questions? The first question is about the notion that to repeat one more Professor Marcello is impossible. So in your opinion, is it really relevant to continue in Ukraine to create multidisciplinary teams to help these patients? What level of knowledge should neurologists have from all the volume of knowledge, and where other specialists are necessary? That was the first question. And let me ask you the second question right away. In your opinion, where should these children get the treatment? In what institutions? Should that be ambulatory centers and rehabilitations, or clinics, separate clinics? And in general, what do you think? Do we need some one central methodological center to help children with progressive neural diseases, and in particular with Duchenne disease? Thank you. These are the first two questions.
Yeah. First of all, thank you very much. And, you know, I tried to do my best in my life. And the problem is that, for example, I work in a little hospital. I didn't get the possibility in Italy to enter at university, but because Italy is a very complex state. For this reason, since the beginning, since 1998, I started to work in hospital. They are not university hospital. They are a small one. And I didn't have the possibility to have all the specialists around me. And my idea was just to try to study as much as I could to be a supervisor. So to try to understand myself what were the problems with the lungs, with the cardiac, physiatrics. For this reason, I went around Europe and also in the United States to try to understand these things. I think that the best thing is to have a multidisciplinary team. But you have to say that, you know, it is not always easy. What I suggest you is just try to I'm an atypical neurologist. You need an atypical neurologist, not a typical neurologist. You need someone that start to understand the study several fields of the neuromuscular disease. It can become like a supervisor. Then you can also teach to the anesthesiologists, to cardiologists, but you need yourself experience. This is the best way to start. Of course, it's very important that in Ukraine there is a center. So if you have a center in Ukraine, you need only one. In that case, everyone can come in the center, can learn in that center. The center can become probably a school teacher center. And I think that is very important that all the, if you have to put money, for example, on the clinics in this moment, also in Ukraine, you should try to really create only one center that works. And in that case, you have several figures. You can have young people that want to try to start with such kind of disorders, become a super specialized neurologist. You will see that slowly, Ukraine will be as probably other countries. What I can tell you is that in Italy, not in all regions, there is knowledge of muscles. I see in Bologna people coming from all the regions in Italy. And I can tell you that also in Italy, we have a lot of problems. There are also today, many hospitals, they do not know much about the muscle disorders. Fortunately, thanks to the association, family association, thanks to probably a little bit of Teleton, now in Italy we have more centers in the big city that are called NEMO, neuromuscular centers. And these are good, and generally a family doesn't need to do 1,000 kilometers to go by a specialist. You can have a specialist in 200 kilometers from your house, for example. But until a few years ago, really, also in Italy, there was a big problem. Then now the situation is better, and probably Ukraine will be the same. You have to start. And when you start, you will see that later on, slowly, you will have more experience and everything will become more simple. And your patients, I'm sure they will be very happy because their life will be much better than now. You can avoid surgery if you follow all the stages. You cannot wait that a retraction form. You have to just start when there is no retraction. And you have to teach a family and let them to understand, also the boys, that it is very important to prevent. If you prevent, your life will be much better. If you arrive too late, then it's impossible, because when there is a bad scoliosis, it is too late. When you have a bad retraction, it's too late. When you know the foot, you have already retraction of the ankle foot that is important, then it's too late. So for this reason, less invasive we are, better they live. For the rest, you know, I would like to collaborate with you, no problem. Probably once come in Bologna, and you know, it's also my story is a very strange story, because we didn't have war in Italy, but we had COVID, probably as you had. And my unit in 2021 was closed because we had to give space to COVID. And for example, I was working in another hospital, I had 14 beds, and they closed my unit because they say, you know, we need the places for COVID. And all my patients were on the street. Now, since 2 months, I open another unit in another hospital. I have 8 beds, not big one. It's very nice hospital, this one. But it was incredible. For COVID, they closed my unit because, you know, they have to give places to COVID. It's incredible. But, you know, Italy, for me, is not probably different from Kiev in this moment. Okay. But I will be very happy if someone of you comes to Bologna. Probably can spend a few days with me, and in that case, you can learn much quicker. Okay. I'm very close to you as people, so if I can help you in some way, I will help you.
Дуже вам дякуємо за
Thank you very much for your response. This is extremely pleasant for us that our meetings will continue. And I would like to go on with my questions, if I may. I think I won't take a lot of time. If too long, Oksana will interrupt me. I'm interested, dear professor, I'm interested in how do you cooperate with palliative therapy departments in Italy. In Ukraine, we also have palliative therapy departments in Ukraine. And you talked, for example, about adult patients. Do you, it's the second question, whether you separate adults and children patients, and how do you cooperate with palliative therapy departments? Two questions in one.
Yeah, okay, I understand. First of all, I have to say that today the medicine is not really prepared to take care about the people that they cannot cure. So for this reason, the palliative medicine and the curative medicine should work together, no? But in Italy, generally, the families are the palliative hospitals, because Duchenne, also 40 years old, they live in the family. Incredibly, the mothers, they have the biggest work for these people. The problem is that when, children become adult, and now I have many adults with Duchenne. They are 35, 40, 45, and the parents are very old. And for this reason, sometimes, they are not able to assist their kids. But, unfortunately, in Italy, we don't have such kind of mentality like hospice, where you can do palliative medicine. You have some for cancer, you have some for amyotrophic lateral sclerosis, for example, because in that case, you are still older than a Duchenne when you become sick. But in the most, all the families that I follow with adult Duchenne, they live in their families. And for this reason, they live in their home. The palliative, we teach them how to do, we teach everything, how to use Sollevator, everything, but they live at home. Then I don't have much contact because they do not exist in Italy yet, hospice for such patients. And the life of a mother is destroyed because many times these women, they were working and they stopped working. So these families, they get a lot of problems because, generally one member of the family become assistant, and 99% of the time is the mother. The father goes to work, and the mother lose her life, lose her job. This is, we work a lot on psychology because these women that, they really need a prize, because many times we give a prize to everyone, but we should give a prize for these women because they really destroyed their life just for their son, and they are very clever. They will never leave a son, also if he's 40 years old, to go in hospice, palliative hospice. I can tell you, this is really, in Italy, is like that. For example, in Japan, I know that is much different. When they are 18, they make them tracheostomy, and they send them to this hospital, palliative hospital. But I don't know which kind of life these boys can do in a palliative hospital, because they are really depressive so many times. I prefer that they stay home and they can live their life, because I think is the best way to have a good quality of life.
Дякую вам.
Thank you very much. Yes, Italian experience is closer to us and more understandable, so we accept the way you talking about it. Oksana, I think there are other questions from other participants. I won't take any more time. Yes, thank you very much. I do have a question for Professor Villanova. The question is regarding organizing the medical aid to such children. I know that mostly such children, such patients come to a physician for one day for a consultation or active therapy, and then they go back home with recommendations. You said that you have a department with beds. In which cases you recommend hospitalization, and how long can hospitalization last, and what does it depend on?
Okay, so generally, when a boy with Duchenne walk, I don't take them in the hospital. I see them just in outpatient clinic. I do a visit and I give suggestions. Eventually, can stay just a few hours if we need to make some orthosis. I hospitalized a patient with Duchenne when you did to check the scoliosis, the heart, the respiratory. So in those cases, I generally let stay them for, it depends, sometimes 1 week, sometimes 2 weeks. It depends by the problems. And in these days, they do everything. We check scoliosis, and we do the corset, we work on the wheelchair, we do on psychology, nutritionist, we check the heart, and they do physiotherapy every day, more or less 2 hours. So all these things, they are paid by the health system. So the families doesn't pay anything in Italy. When they come in the hospital, they can stay 1 week, 2 weeks, it depends. There is a prescription made by the general doctors that ask to the clinic to help their patient. And in 7 days, maximum 10 days, I try to do everything. So if I need a corset, or if I have to ask some consultation from some specialist, this is the way. So I do these works more than 20 years, and I do always the same. I don't put inside in my hospital kids 5 years, 4 years old with Duchenne, because you don't need to do it, and probably it's better if the kids are out of the hospital as possible as they can. Unfortunately, if you come from another country, you have to pay. This is a problem. And sometimes, you know, people from Ukraine, Russia, they ask me, you know, I want an help, and I let them, okay, come in Bologna. I will see you in a visit. I can do a visit, but it becomes very frustrating, because then you let people come back in your country, and probably the boy needs many things, and probably these countries are not able still to give this kind of aid that boy needs. This is also, for me, is frustrating. But if I ask a family, okay, you can stay in my hospital for 7 days, we can try to do everything, then you need to pay. This is a problem, because you are not covered by the health system, Italian health system.
Дякую. І скажіть, будь ласка,
Thank you. And could you please tell us about your experience, what hormonal medications you use and in what mode? Because once again, you presented there are certain modes. What is more preferable to you? What is the mode of prescribing medications, hormonal medications?
So you are asking me about hormones. So hormones, you mean growth factor hormones, not steroids?
Стероїди, ні, про
No,
стероїди.
I mean
Steroids.
steroids.
Okay.
Steroids.
Steroid, not because sometimes, you know, about the low stature, about sometimes you can have also problems with sex genitals. So sometimes, you know, parents ask also hormones for other things. But anyway, steroids. I generally start, as I told you before, I start with when they are 3, maximum 4 years of age. It depends if I can do some tests and then be sure that the steroids works or doesn't work on that boy. I start with the 10 days yes, 10 days off. And this is my first scheme. Then I ask the parents to come after 6 months, and I try to understand whether that schema improved or not the boy. You have to think that until the age of 5, all boys with Duchenne improve. So you don't need either to. So if you don't give any steroids, they will improve the same, because Duchenne until the age of 5, the strength improve, then become stabilized, and then they start to go down. The steroids, the work of the steroids, just to let the strength go upper than 7, 8 years of age, in which they generally could stop walking. With steroids, you can try to let them to walk until 10, 11. If I'm not happy about that schema, I start with every other day. Otherwise, I do every day. It depends. So, you know, it's the clinician that decide which is the best schema for that boy. It depends by the results. Sometimes, you know, I've seen patients with Duchenne that has been taking for 3, 4 years every day steroids. Then they are very fat. They have a lunaris face, and no one checked, for example, whether this schema was really necessary or not. For example, it's not just give steroids that you solve the problems. You have to do a lot of tests to understand if that schema works. If it works, you don't need to give a lot of steroids to the body. So it's a very, the therapy is subjective, it's very subjective.
Маргарита, чи є питання у батьків?
Margarita, do parents have questions? I see a question in the chat. They ask, Mr. Professor, have you ever noticed in your practice iatrogenic steroid myopathy, due to which you had to stop treatment with steroids? If so, how frequently do you see such cases?
Well, you know, iatrogenic myopathy exists. There is a form when you give steroids to a normal person and you give steroids for a long time, you can have an atrophy of the type 2B fibers of the muscles. And in that case, you can speak about myopathy, iatrogenic myopathy. In Duchenne, the iatrogenic myopathy does not exist. Practically, what you can have is only side effects of steroids. And for this reason, it's very difficult to understand whether Duchenne has eventually a iatrogenic myopathy. What you can do is just check whether the steroids help or doesn't help a boy. So as I said before, when you give steroids to a boy, you have to check it. And you cannot give steroids and then see the boy getting fat, doesn't the strength didn't improve, he will have a bad osteoporosis. So in those cases, we can call iatrogenic side effects. In that case, you know, you have these problems because no one was careful to check the side effects, you understand? But iatrogenic myopathy in Duchenne practically is impossible to detect. You can have iatrogenic side effects. You can speak about iatrogenic myopathy, whether, for example, in Duchenne, you give steroids and after 6 months, the strength of that boy decrease. In those cases, you think that probably the steroids has a bad effect, but this is not my experience. I never seen such things. I give also steroids when they stop walking. But in that case, generally, I try to give less steroids. So I'm not following more the schema that I follow when they walk. Because when they stop walking, well, it's important to give steroids yet, because probably it's important for the heart, for the lungs. But you don't need to give steroids, kilos of steroids, also in a child when start sitting, and the results are good.
Скажіть, будь ласка, у мене
Could
таке
you please tell us? I have a question. Right now, there are a lot of children in Ukraine, and probably most children in Ukraine for a few years take corticosteroids. So right now we have a different question about the fact that these children have problems with the bones and develop osteoporosis, and very often these children fall and they have bone fractures. Could you tell us, please, what are the main risks of fat embolics or
Yeah, allora, fat embolia is a very bad situation. I got in 20 plus years of experience only 2 cases and of fat embolia. Fat embolism, you can have a fat embolism in Duchenne also with the very light trauma. You don't need to have fractures to have a fat embolia, because if you have also a light trauma, sometimes the muscles, because there is a lot of fat, can break. So in that case, you don't see fractures, but the boy get respiratory insufficiency. The problem is that because these boys can change their situation in few hours. You see a boy that is okay, 98% of saturation, he fall, and after a few hours, he get incredibly bad. And he start to have a tachycardia, he start to have, for example, respiratory insufficiency, and then you go to the emergency room. If they don't know what is a fat embolism, the boy died, because most of the time when you have a fat embolism, the boy died, because if you don't intervene immediately with transfusion, with special ventilation, you lose the boy. So fat embolism is risky, but I have to say the truth that in all my experience, hundreds of Duchenne, many of them fall, and a few of them they got fractures. I got only 2 cases. So probably we have to understand why fat embolism is rare in the rare. Many times you fall, you don't get any fat embolism, and other times you do a stupid fall in which you don't think anything, and then you get fat embolism. But the important thing is that you have to know it. And if a family is in difficulties and see the boy that changed completely after a fall, should call immediately the doctor, and the doctor should call immediately the emergency room to tell colleagues, wait, could be this, because really it's a very, very difficult diagnosis. Very few people know about fat embolism. You understand? About osteoporosis, I have to say the truth. Generally, in the past, when we give steroids without doing any check, many times the boys got fractures of the somatic vertebra in the trunk. So, and they had always pain, because, you know, when you have a osteoporosis very, very severe, you get pain. But in the last 20 years, I didn't get any more bad osteoporosis. Of course, everyone has osteoporosis of them. But important is that they don't get spontaneous fractures. When you have spontaneous fractures, it means that you have very bad osteoporosis. Then you can do densitometry. The densitometry, once a year, you do densitometry. It's not always easy to do densitometry, because you have to have also experience in people 7 years old, 8 years old, and many times densitometry is made for women, for adults. And who does densitometry has no experience with the kids. But anyway, this could be a good exam. You do it until they walk, then it is not necessary, at least for what is my experience. So we can check, but give vitamin D, give a bit of calcium. If you give calcium, tell the parents, let him to drink more, because sometimes you have stones in the kidney for calcium. Because these in Duchenne, especially when they stop walking, they don't like to go to the bathroom because they have to go by the wheelchair to the toilet. And these, for many times, they don't go to the bathroom because they don't want to get noise, or because, you know, they have to do something and they get bored to go in the bathroom. But it's very important to give more water to them because they don't drink much many times. If you give calcium, you have to give a bit of more hydration. Then you can give a biphosphonate. For example, from the age of 10, I give a biphosphonate. Low dosage, but I give them. Today, in some hospital,
sorry,
Italy,
biphosphorate?
Biphosphonate. Today, in some hospital in Italy, because you need to have a public hospital or at least a university hospital, they do also biphosphonate intravenously, in case there are studies on it. But for what is my experience with vitamin D, calcium, and biphosphonates, when you start, not when a boy is 30 years old, but for example, when he's 12, 13, it's a very good choice. And I didn't see bad osteoporosis in the last 15 years. Okay.
I have one more question. The UK, Great Britain, doctors provide consultations to parents about injections, how to give injections to a child, or hormonal injections in case when the child cannot take the pill or swallow the pill. Is this practice used in your hospital or in general in Italy?
Well, in my hospital, not. I think it's very invasive, and I never got a child that doesn't can take pills. So we have drops. So we give the Flazacort in drops, and many times they put the drops in the Nutella or in mortadella, and then they take the drops. But I never give injection of steroids because they cannot take pills of drops. I think this is a very invasive way to give drugs. I don't like much invasive way. So I don't do it.
It's clear. Can I ask one more question? Because I have a few questions to ask, but please, the floor is yours. One more question from the chat, probably from parents. Could we ask you, what is the approximate price to stay in the hospital for children from Ukraine, in your hospital, as I understand?
Yes, tell the parents that, you know, I don't like generally to speak about this because, you know, it's not my fault. But if they want, they can write me an email, and probably I will ask the hospital if they can do a special price. I don't know. But now to speak about price today is not really the target. Generally, one day probably could be the cost of, I don't know, 400 euros a day, more or less. But really, I cannot be sure because I arrived in this hospital 2 months ago, and I have to understand something. But tell the parents if they are interested, they can write me an email. Okay. But you should stay in Ukraine, not come in Italy.
Володимире Юрійовичу, будь ласка.
Дякую. Ну, я хочу знову ж трошки...
Then again, I want to receive some professional opinion from Professor, if I may. So I want to ask you the following. Since we understand, and that's absolutely right, we understand that there is the practical experience about all the methodologies that are used in treatment. Let's take physical therapy. And it was emphasized in your speech that there are more weak muscles, stronger muscles, and you clearly know what muscle groups suffer more, and specific approaches appear. So my question is, are there some polished off methodologies of physical rehabilitation, or is it your personal work result? As an example, for example, for many years we heard that voltotherapy methodology is used in treatment of patients with Duchenne disease. As an example, could you please share this experience with us?
Well, I say that the most important thing is that you have to avoid retraction. Now, I generally suggest to the parents the best sport they can do is also swimming. Swimming is very good because, you know, you move the muscles, you don't push much on the bones. Of course, you have muscles that are weaker and you have muscles that are stronger in Duchenne. For this reason, what you have to do is to try to keep the length of the limbs as straight as you can, because if for example the lower limbs will develop bad retraction, that the boy will have problems to walk. The physiotherapy is important, but you cannot change a lot the natural history of the Duchenne muscular dystrophy with physiotherapy, manual physiotherapy. You really need to put orthosis. The physiotherapy can be good because anyway you move better some limbs. Generally you cannot move much, and this gives also to a boy a good feeling. And for example, the physiotherapy can be very good for about the respiratory physiotherapy, because we do a lot of hyperinsufflation exercise to make stretching of the respiratory muscles. We do it with the calf assist. So if you have a calf assist machine, you take away the negative pressure, you use only the positive pressure. In that case, you can hyperinsufflate the lungs, and then you can make a very good physiotherapy. And we have seen that when you start chest physiotherapy already at the age of 10, you have good results. Probably you can delay the necessity of non-invasive ventilation. Well, some of my patients that did this kind of physiotherapy, we have seen that they delayed the necessity of ventilation. For the rest, you have to use orthosis. You need to have a good orthopedic clinic in which they can do good orthosis. For example, the ankle-foot orthosis are very important. And they have to be light, they have to wear very well the foot of the boy, and they have to be well done made. In that case, the child will accept. And when you put them during the night, you can be sure that the foot will be always in a good shape, at least until the age of 10, 11. So you don't need to do surgery. The same for the corset. For example, you know, it's probably, there are other, as I said before, there are other colleagues that will tell you, no, don't put a corset because you don't need. This is not true. So the corset is very important, should be made very well. So you have to respect the ventilation when you do the corset. Our technician let the patient breathe, because, you know, if you don't do a good corset, they can, or you can also make in difficulties the lungs, because if it's not good, it means that the lungs cannot work very well. But if you do good corset, if you do it when the child stop walking and start to sit practically all the day, can be very good also for the scoliosis. Then the standing is very important. So we work on orthosis, we do physiotherapy, because physiotherapy is very good, because psychology also, because you can try to avoid the retraction, but you need really to do physiotherapy every day. Many times the health system pass just once physiotherapy a week. Practically is very ridiculous. Also in Italy, happens like that. There are families that go to the health system and they give, you know, I give you physiotherapy once a week. You understand that the once a week doesn't do anything. And sometimes they tell, you know, it's the family that should do physiotherapy. This is not correct. A mother is not a physiotherapist. So the mother, okay, is a mother, but cannot make the work of physiotherapy. This is just a way to try to avoid expensive from the state, but this is not correct because it's their right to have a physiotherapy. I do a lot of work about this. And when I listen some, you know, bureaucratic office tell to the mother, yeah, but you should do yourself, the physiotherapist, you know. No, the physiotherapist make physiotherapy. The mothers does the mother. Yeah, the mother can do something, but the mother has already a lot of things to do. I don't know if I answered your question, but you know, I work orthosis.
Абсолютно дякую. І я в зв'язку з цим хотів запитати.
Thank you very much. You fully answered. And I would like to continue my question. Do you use in your practical experience, do you use machine physiotherapy like vibrostimulation of muscles, some perifine application, some electrophoresis?
Yeah.
How do you use these devices, some devices, any devices for physiotherapy?
Well, generally, I do not use this kind of device. You know that electrostimulation, the word studies was very bad because, you know, when you use this device, you can stress the muscles much more. For example, electrostimulation is not good for Duchenne. I never use vibration, and someone say that vibration can work. Probably in Milan, there is a work now on a vibration platform for these kids, and probably they say it can be good for the bones and to avoid, for example, worse osteoporosis. But in my unit, in my hospital, I never use machine for Duchenne. We work with cycloergometry. We work with a lot of manual physiotherapy, orthosis. But actually, until now, I have no experience with the device. I never used.
Дякую вам.
Thank you very much. And I also would like, finally, I would like to ask you the most complicated question. This will relate to the following. Are there any protocols by Professor Marcello for treating Duchenne patients, children in particular?
Well, you know, I never made a protocol myself because I have no unit with many people working with me. And generally, I try to follow protocols that were made in the United States, in France, and I try to improve some of them. But to make a protocol is very difficult because, you know, you need many years of follow-up, and then you need the people, you need a lot of time to take all the data. Unfortunately, until now, well, I published some paper on the ventilatory problems, but I was not able to write a protocol myself because it probably does not exist a Villanova protocol. What I can tell you that the families are happy and the boys are happy, and I have a lot of adults with Duchenne. We work on the families, on the boys. But if one day I will have a big institute, then probably I will try also to write a protocol. You know, the pity is that I have not many people work with me. If you come in Bologna, you will see actually I'm alone with only physiotherapists. And for this reason, you have not much time. You have so many things to do every day in the hospital. And then you should need really as a research team to do and to work on this protocol. But I don't think I said something different from other centers. More or less in the world, we do all these things. I was the first in Italy to bring in Italy the cuff assist. When I arrived in 2000 from Newark, from John Bach in Italy did not exist the cuff assist. And when I started in 2000, I was neurologist. The people, also colleagues, try to tell me, you know, this is a neurologist, he's not a pneumologist, he doesn't know anything. This machine the Duchenne doesn't need of this machine. So I had a lot of people against because, you know, I was speaking about cuff assist. And now everyone uses cuff assist. And as Bach said, in the medicine, when you do something new, everyone gives you, is against you. Then after all, they say always that they always did it. This is a teaching from medicine. So I did a lot of work during my life, and still I make a lot of work, bureaucratic work, fortunately, not work like yours, to let the people, to let the bureaucracy respect these families. There is no respect.
Дякую вам. Я думаю, що
Thank you very much.
велика команда.
I'm sure that ahead you will have a big team of experts, of specialists, and people, your colleagues and bureaucrats also will listen to you, and you will have an opportunity to draw and write many protocols, not just one. Finally, I would like to ask you my last question. What is,
Професора Марчелло,
according to your belief, Professor Marcello, what is the criteria for efficiency of helping a Duchenne patient? What is the criteria for assessing whether the medical aid to such patient is efficient?
Yeah, well, you know, yeah, I don't know if if I understood very well your question, but if your method is efficient, then you see immediately how long they work, how long they live, how good is their quality of life, and also the best method to understand if your method is correct is that you have to prevent. You should never arrive when the ejection fraction of the heart is 30, and you see it for the first time, your ejection fraction that is 30 of the heart. You should do the follow-up, you should check everything, and I think the best method is just to try to avoid problems, unnecessary problems. Otherwise, unfortunately, the Duchenne die. But today, what we want is that we want to prolong their life as much as we can. And we want that these boys become adult and they have quite as much as possible a normal life. So this is the best method. If you work with the heart, and if you work knowing that you are trying to do the best, you are applying the best thing in the world for that boy, then your method is okay.
Я вам дякую за вашу відповідь.
I thank you so much. Oksana, the floor is yours back. Thank you very much. I also have two questions actually, but I'm interested that since there are now, since physiotherapists are lacking in Ukraine, most of this physiotherapy is done by parents in Ukraine. So what about Italy? What is the sequence in your case? After you gave recommendation, how much work is done by parents, and what is the involvement of the physiotherapist?
So fortunately, in Italy, everyone can get also physiotherapy by the health system. So generally, we teach parents to do a bit of physiotherapy, but most of the time they do physiotherapy in places where you do physiotherapy, so they don't do physiotherapy at home. When a boy walks as a child, what I ask, just let him to go in a swimming pool if you can. then they use orthosis at home. So we let the parents know how to do, for example, stretching of the ankle, but they don't do it at home. So there is always the possibility to go to do physiotherapy out of their house. So the parents are involved because they follow everything. And when you live in a place where, for example, the first place of where you can do physiotherapy out of your house is 100 kilometers from your house, then in that case, you do physiotherapy at home. But most of the time, you know, it's not very good that the mother does physiotherapy, because many times the boy doesn't like much. Probably you should do so many hours of physiotherapy to get results, that I prefer in those cases to give orthosis. But families are involved, are 100% involved in all the stories. In Ukraine, you do everything yourself, so you don't have the possibility to do physiotherapy in places where physiotherapists do it. So the mothers does everything at home, so you do physiotherapy at home for these kids, or I don't know.
Yes, in most cases, because in Ukraine, we don't have enough physiotherapists, and besides physiotherapists who knows how to work with children with neuromuscular diseases, there is such problem, and we really try to find the way how to train physiotherapists so that they would get to know these particularities.
Yeah, but remember that when you use orthosis, for example, if you put orthosis when they are really 3 years old and orthosis are good and they walk much longer, the good physiotherapy for them is just to walk. And if they have good feet, it's okay, it's good physiotherapy. So don't believe that the physiotherapy, the end of physiotherapy, manual physiotherapy will change a lot the natural history. No, the natural history of these boys will change if you use also orthosis, and if you let them to walk longer. So they will have less scoliosis, they will have less retraction. For example, when they stop walking, you don't put them on a wheelchair and finish the story, because in 6 months they will have a retraction of the hip flexors, of the knee flexors, of the tendon Achilles. When the retraction of the lower limbs are bad, they will not sleep very well. They will call the mother 10 times, 20 times a year during the night, because you have to move them, because they have so bad retraction. The quality of the sleep is not very good, and the quality of the sleep of the parents is not very good. Remember, better is the condition of your son, better is the life of the parents. Because many times, if the boy sleeps when he's 20 in a good position, they will not call the parents 10 times, 20 times a night, because they want to move that, put a pillow there, put a pillow there. So you understand that it's very important to avoid bad retraction. If you let's stand them also when they lose the possibility to walk autonomously with the standing frame or with the wheelchair, you will see that their life will be much better.
Thank you. I have a question, if I may. Maybe it's going to be the last one. Please tell us, in what case would you recommend for parents to give the child the stress dose of steroids, or is it impossible for parents to do it, and it can be done only upon prescription of the doctor?
Well, I have to say the truth, I never use stress dosage for steroids. So generally, when you do such thing, it's better to do it in a place where you know you have a medical care. For what is my experience, is not really necessary. These are trials that are made to understand better if the steroids work or doesn't work. You know, unfortunately, we have not yet a good job that tell us which is the best dosage. And despite the fact that are more than 20 years that we use steroids, we don't know yet if we give 0.5 milligrams to kilograms to the kids, if it is the same as to give 0.75 prednisolone, for example. Because most of this research in the last years went on the genetic therapy. And nobody studied more the steroids. Now, in the last year, there are a few trials that are trying to study the better dosage, because probably these kids, they don't need to have 0.9 milligrams per kilo of the Flazacort or 0.75 prednisone per kilo probably they will go also very well with 0.5, but we always give 0.75, 0.9 because we learned by the trial that was the dosage. But those trials are not well done. So I think that we have to learn still a lot about steroids, and probably this kind of stress therapy gives once a week. They are all tentative to understand if we have a better schema to give steroids to the kids. You know what? If you give steroids 10 days, yes, 10 days, no, you try to save the cortical surrenal gland, because if you give steroids for 10 days, then you can stop it. The cortical gland will not suffer. If you give steroids every day, then you will suppress the production of our steroids, because we produce ourselves steroids. And for this reason, this can become more problematic in the course of the life. For this reason, I start with a schema that doesn't give a lot of noise to the normal physiology of the boy or the kids.
Дякую.
Thank you.
Okay.
We are about to finish our meeting. It went very quickly. Thank you so much for all the practical advice to treat our children. So I want to wish you to have Merry Christmas and Happy New Year, because holidays are coming, and really it was very nice to listen to your presentation. Mr. Volodymyr, could you say a few words? Please unmute yourself. With pleasure, I join the words of Oksana, and my personal wish is to have the possibility to listen to your practical experience in Ukraine among the specialists and parents. Maybe I have no right, but I want to sincerely thank you for the help which is provided to the Ukrainian people in their difficult fight with the Russian aggressor. Thank you so much for your help, and we look forward to seeing you soon in 2023. Thank you.
So
Thank you.
I thank you very much. For me, it's been a great pleasure to be here. I hope really for Ukraine to solve all the problems, that you start to have again a normal life. You see, as a colleague, I work in a trench. It's like war. I work in a trench every day. So when I speak because I have people that show me these results. So I don't have much time, unfortunately, to write papers and papers, because I have a lot of work every day. But if someone of you want to see the reality, I will be very pleased to let him to come into Bologna and see these kids, this family, and in that case, also with colleagues from Ukraine, we can have a really very concrete collaboration. And I invite you, the colleague, the professor, to come to Bologna once. We can spend some days together. So we can speak about many things, and I can show you how we work. on these families. Okay, so Merry Christmas to all of you, and thank you again. And it's okay.